Now, from the News Channel 5 network, this is Medical Mondays.
Good evening, everyone. Welcome to Medical Mondays. I'm Carrie Sharp, joined again by Dr. Dan Wunder. We appreciate you being here, Dr. Wunder. Always glad to have you. An interventional radiologist, and we should say from the get-go, this show tonight is for the ladies, or perhaps if you love a lady who is dealing with pelvic pain. That's what we're talking about tonight, uterine fibroids.
Correct.
And a lot of women suffer from this. I know just even women in my age range, as everyone was starting to have children, a lot of my friends ended up having to have surgery for this so that their fertility would go up because they were in such pain and having such problems. I'm sure you see that.
Yes, yes. Not so much on the fertility side, more on the pain side and the pain pressure kind of side on the symptoms.
We were talking before the show. I said, well, how do people end up in your office? Because you're an interventional radiologist. I would think if you're having uterine fibroids, you go to your OBGYN, and you said women are really smart, which we all know that. And when you're dealing with fibroids, sometimes you don't want to have a hysterectomy to deal with it. You want an alternative, and that's what you offer. Yeah,
that's correct. There are several ways with dealing with fibroids, uterine fibroids. And it kind of runs the gamut from medical therapy up to surgery. There's several things in between. Interventional radiology, as you know, is that minimally invasive option. You know, you can get it done the same day usually and get back home without big scars and surgeries and such and lots of pain. So the fibroid embolization process is just kind of a modification of the procedure that we've used for many years to control postpartum hemorrhage in most women after they deliver babies and their uterus won't contract.
Right.
We always get called in to embolize that uterus to help shrink it down, stop things from bleeding. And this was figured out in France back in the 90s. They found out that if they embolize, the French gynecologist realized that if he embolized the uterus on these postpartum patients, when he would go look later, and he noticed the fibroids were smaller. So he started asking interventional radiology to embolize the fibroids before he did like myomectomies, which is not taking out the uterus, but just the fibroids themselves to enhance pregnancy and such, so that you can carry a baby, and symptoms, of course. And when that happened, he noticed that the surgery was much easier. And so they actually took it one step further and just stopped surgery and just treat the fibroids, in most cases, with just the embolization, because it'll shrink the fibroids and diminish the symptoms. So that's kind of how it really got its foothold, and then it kind of picked up over here, and later 90s, 2000s, and it's gotten progressed since then and become more and more prevalent in certain pockets, usually for the most part, not everywhere, but women do their research on the internet.
Oh, yeah.
I always say it's funny when a man comes in to get a procedure, he's always like, just do whatever, do what my wife says. And when a woman comes in, she goes, I've already read about this, I researched it on the internet, and I want to have this done. She's like, I know the options. It's like, it's refreshing that they know. So
yeah, you got to be in charge of your own body, that's for sure. We've really jumped in with 2 feet here. I want to back up the train just a little bit. If you have a question about uterine fibroids and you want to explore different options than a hysterectomy, go ahead and give us a call tonight. 571 or 615-737 plus is the number to call. I don't know what number I'm giving out. 615-737 plus. That is the number. As always, we will take as many calls as we can tonight. I want to go back here. What is a uterine fibroid?
Okay. A uterine fibroid is a benign, it's called a leiomyoma. It's a benign soft tissue tumor of the uterus. No one really knows what causes them. They just grow. Most women over the age of 50 have them, quite honestly. And, they start out little in size, a centimeter. We can see them with ultrasound. We can see them with MRI. A lot of times they're picked up on a pelvic ultrasound a woman has for another reason. And we can just, we document them, of course. And if they get bigger, then they start to cause symptoms. They cause, bloating and distension and pain, pain in your pelvis, pain when you go to the bathroom, both types of going to the bathroom, pain with intercourse, all kinds of these. And of course, the biggest thing is lots of bleeding. I mean, women have, that's their biggest complaint.
Sure.
They have they go through a lot of sanitary napkins, etc., to control things. Sometimes and they're very painful. a lot of cramping that goes on with it.
So much so it changes a woman's lifestyle. I mean, it's that heavy.
Yes. I mean, they get anemic, too, so they're taking iron. Iron's tough on your stomach, so your stomach hurts. And a lot of these women, I mean, it alters, how they can do things and what they can do because of the
just have to deal with it.
Yeah.
Exactly. When this starts, when people are starting to deal with these types of interruptions in their lives, do you find that most women at first don't know what they're dealing with? It's kind of like a scavenger hunt to find out what the problem is?
Well, to some degree, usually by the time they get to me, they've figured it out. But we don't. We're not seeing 3 or 4 people a week for this either, quite honestly, which we probably should. But a lot of times they go see their family doc or their gynecologist, and they have this problem. And of course, they can get started on oral contraceptives to help control the fibroids, birth control pills, or some other medicines that can help shrink the fibroids. But usually, when you quit taking those medicines, and they come back, because the hormones native to your body you're fighting basically. After menopause, when your hormones change, then those fibroids shrink anyway. Oh. So a lot of women, that actually have got to me, they are kind of trying to bridge that spot from 40 to 50 or 55, so that they can avoid a hysterectomy. That's really what they're doing for most of them, because they don't want to have it. But a lot of women are just, the ones that come, show up, have research. The ones that don't show up, I can only presume what's happened, but it's just an option that people should know about. It's an option between medical therapy and hysterectomy that is important to know about.
And let's talk about why not hysterectomy. I mean, it certainly solves the problem.
It does. There's there's risk with anything we do. There's risk with embolization, and I go through that with the ladies. There's risk with a hysterectomy too. I believe, but I mean, a good gynecologist would argue too that in their hands the risk are both low, and it's straightforward. I think the recovery though is a big thing. The recovery is a lot faster from a fibroid embolization. There's no hospitalization. It's done in our outpatient setting. We make sure that the ladies are real comfortable. We check on them afterward. We make sure that they have a good armamentarium of medications to take care of any kind of discomfort. And then we see them back and make sure that the fibroids are shrinking, their symptoms are getting better. So the biggest thing I think is, most women are busy. I mean, we're all busy, but a lot of women have careers and such. And if they don't have kids in their careers, they're at home with their children, and they don't have a week to 10 days to take off, to not do much, not drive or whatever. They may have 2 or 3 days. They say, I want to get back on it.
Yeah.
So that fits that niche.
So you can do this in the office and the women go home that day?
Yes, ma'am.
Wow. That is quick. That is certainly quick. When we come back, I want you to walk me through what the embolization is, like how it works, and then the downtime and all that goes along with it. So we're going to talk about that when we come back again. If you have a question about uterine fibroids, tonight's the night to get some free help and free advice with that. Go ahead and give us a call. 615-737-PLUS is the number to call. We're coming right back.
If your home is unusually dusty and you have black lines around the edge of your carpets, then your home needs Mr. B's air duct cleaning.
We have been tested before, and we know as far as the airborne particulates in a home that we remove the actual 53% of the dust out of a home.
And you can trust Mr. B's. Their technique of air duct cleaning is Middle Tennessee's most thorough.
We want to be absolutely the best at what we do. It's only one way, and that's the right way, and that's the way we do it at Mr. B's Air Duct Cleaning.
Oh, beautiful for spacious skies, for amber waves of grain, for purple mountain majesty, above the fruits and America.
This is your view every morning. Sky 5 rises and shines just like you do.
This is Sky 5 Live.
To get to the news you need faster than anyone else. The only full-time morning news helicopter.
Bumper to bumper in some areas.
Sky 5 is a difference you can see every morning. Only on News Channel 5. If you spend any amount of time at the great outdoors, hunting or fishing, you need to watch Southern Woods and Waters on News Channel 5 Plus. Join host Hugh McNaughton and our area's top sportsmen as they share their experience and knowledge. Southern Woods and Waters is all about Middle Tennessee, and it's live. Call in with your questions. Whatever the season, that's what they're talking about. Tune in to Southern Woods and Waters Thursday night at 8, or catch the encore presentation Sunday night at 8 on News Channel 5 Plus.
Welcome back to Medical Monday tonight. I'm with Dr. Dan Wunder, an interventional radiologist, and we're talking about uterine fibroids tonight. If you suffer from these, you know it. Now's your chance to get some advice if you're searching for solutions. And we have some folks on the line. Let's get right to the lines. Rebecca calling in tonight. Rebecca, you're our first caller. Thanks for being on the line. What's your question?
Hi. Can you have uterine fibroids, endometriosis, and endomyosis all at the same time?
Yes, you can. You can. Endometriosis can't be treated with embolization, though. Endometriosis.
Okay, because I had it all three, and I chose to have a hysterectomy at the time, and it was like the best thing.
Yes, ma'am. The endometriosis, that's the lining of the uterus. It kind of gets out of the uterus and goes other places in the pelvis. And it can, every time your hormones change, then that proliferates. It can cause a lot of pain. So yeah, that's a different deal. That has to be treated in the fashion you had it treated.
Now, most of your patients, are they just dealing with the uterine fibroids, or do you see kind of a stacking of issues?
Sometimes you get the fibroids and the adenomyosis. The adenomyosis is where the whole uterine muscle kind of gets infiltrated with a similar process to a fibroid, just kind of diffuse though. But you see that, and then we see some people with pelvic venous congestion where the veins don't drain out of the pelvis well enough, which causes pelvic pain too. So that's a kind of not a common combination. It's a little more common than the endometriosis.
Okay.
That doesn't usually end up showing up to me because that does get treated surgically. Yeah.
All right, let's talk to Levon. Levon, thanks for being part of the show tonight. What's your question?
Yes, I have had heavy periods, and they all of a sudden quit like 3 years ago. Then I guess I went on into menopause, and I was wondering if that is common.
To go from one to the other, or what?
Yeah, to go from one to the other.
Go from very heavy to nothing at all.
When you go through menopause?
Yes.
Yes, ma'am. That's pretty normal.
Alrighty.
All right,
Okay.
Thank you, Levon, for calling in. Let's talk about the folks who show up in your office. And you said most people have been told you have uterine fibroids, and they start searching for solutions, whether to do the hysterectomy or the embolization. They show up in your office. What do you then do?
The first thing we do, of course, we want to make sure that they have, if they don't have imaging of some sort, we get it, like an MRI or a pelvic ultrasound to, document what the fibroids, how big they are, how many they are. That's important as a baseline. The biggest thing, though, is their symptoms. I mean, we're treating their symptoms. You're not going to make the fibroids go away with an embolization. You're going to shrink them so that the symptoms stop or decrease. That's what you're trying to do. So you get the imaging. It's always good to have a recent pap smear that's negative, because the last thing you want to do is have somebody that comes to you that is bleeding, that really they haven't come from an OBGYN that has worked them up. You want to make sure you're not dealing with a tumor in the uterus or endometrial tumor that you're embolizing and giving someone false security.
Sure.
So those things are on the front end of things, basically. And then we do a consultation just like we do with the kyphoplasties and the peripheral vascular disease. So we know their full history, surgical history, social history, all that stuff. And then we spend quite a bit of time, we give them some materials, of course, but quite a bit of time just going over the process of how the embolization works, what the day is going to be like at the office. They're usually there for about 4 hours. And then what the recovery is like, and when they go home, and that's probably the more important thing for them to understand. Because when you embolize a uterus, I usually tell the women it's going to be like you're having a very, very bad menstrual cycle because that uterus, you're taking away the blood flow from it, pretty much the whole uterus. And so it's kind of screaming for something. And so we make sure that they're covered with, pain medications of different sorts and, injections and steroids and all kinds of stuff to make that first evening better. And it's really, the scale is wide open top to bottom as far as some women are like, hardly even noticed you did anything. And then I have, one or two ladies that, had quite a bit of cramping for almost up to a week. So that's not very common, but it happens. So
okay, so we know about the consultation now. Walk me through what happens the day of the embolization. Okay.
Day of the embolization, they get prepped essentially like an arteriogram, which probably doesn't make any sense to anybody, but they come in, they get an IV, we give them antibiotics, they get some IV Toradol, which is an anti-inflammatory, they get sedated. We put a Foley catheter in them because you need to see the uterus, the bladder's in front, so that gets, when they're sedated, that gets done by my nurse. Then we sedate them. We put a needle into the artery after we numb up the groin on the side and steer catheters up into one catheter from one side, goes into the uterine arteries, which are in the pelvis, one on each side. We go over to the left side first, I usually do. We do an arteriogram. We see the arterial flow to the uterus and to the fibroids. And it's very classic.
So you're watching where the blood goes.
We inject just like a heart cath, same thing, but where it's the uterus. When we inject it, we can see exactly where the blood flow is. And then when we have that good map, we very carefully inject microspheres. They're tiny spheres, 300 to 500 microns in diameter. Wow. You can't even see them, they're so small. So we mix them with contrast. And then as we slowly puff that in, we can see how the blood flow starts to slow down as these little beads are stacking into those arteries and just packing them shut. And then after we get what looks appropriate, then we pull back and we go over to the other side and do the other side because they're fed from both sides. Now, so you basically embolize the uterus and any fibroids in there. And you've been very careful with where you put the catheter to avoid what we call unintentional embolization, which means we don't want any of those little particles to go to like the ovaries or to the urinary bladder or other things that are down there. We don't want to hurt those if we can help it. And then after we feel pretty confident we've got everything done, pull the catheter out, put a little stitch in the artery, Foley catheter comes out, they come into recovery. So that whole process takes about an hour-ish maybe, and recovery is about an hour. Then we discharge them with their family home.
And they're supposed to stay off their feet for a while, right?
No, they go home. They can walk out. They walk out the door.
Oh, okay.
Because there's a stitch in the artery, so they can walk. I tell them to go home, take it easy. They still have some sedation on board. We give them quite a bit of other medicine to have with them, so they go home and rest that evening. Tell them they can't drive for a day because the narcotics in their system. Really no heavy lifting for a couple days, mostly because of the puncture site or the artery, and that's really cautious. It's probably overkill, but and then we check on them that night, and about a day or two later we check on them again, and if if they're having any issues, we keep checking on them. But otherwise they come back in about 3 months for an ultrasound, and then 6 and 9 months you can do the ultrasound or MRI. Because you're going to see, watch those fibroids, you want to see them shrink over time. And it doesn't happen right away. It takes, up to 6 months sometimes. But you want to, if you can see a shrinkage of about 20% in diameter, so if it's a 2 centimeter fibroid and you can shrink it down 20, 30%, that's a 50% reduction in volume. So if you achieve that, then that's a great thing. So about 75, well, actually, it's more about 85% to 90% of women get good relief of their symptoms.
Just by shrinking.
Just by shrinking them without, because they're going to still be there.
Right.
They're not coming out. And it's very rare to have to redo an embolization, but sometimes you do if their symptoms persist. Usually give them up to almost a year, and if they're still having symptoms, we can go back in and re-embolize.
Now, women who have had fibroids and do the embolization, are they likely or unlikely to grow new fibroids?
They can actually. It's not real common, but they can. So, and that's why, the embolization process, if you had to, you could repeat it, repeat it. It's not the intent, but you can. It's not like, surgery where you operate on something, there's a whole bunch of scar tissue. Next time you're going to go in there, it's going to be really hard Embolotherapy isn't like that, where we put those particles in. They're going to flow to the area of most flow, and they're going to stop. So if you put them in, like you have a big fibroid that brings a bunch of those particles in and stops up the flow, and that fibroid goes away, and 3 years later the lady gets new fibroids, you inject again, it's going to direct to the newer fibroids that are because they make the vessels dilate so that they pull that blood flow to them.
Is there a size that matters when it comes to the fibroids that makes somebody a good candidate for this or not?
Initially, when a lot of this was, ramping up in the U.S., they really wanted you to stay away from the real big fibroids, like the 20-centimeter fibroids. That's pretty big.
Yeah.
And we still try, to let the people know that those are a little bit more troublesome.
I mean, that's taking up space in your body.
A lot of space. The reason being is that the bigger they get, and when you embolize them, they can outgrow their blood supply, and so the middle can get necrotic or infected.
Yeah.
So there is always that little risk. It's not big, it's less than 1%. But there is a little risk that they may still have to have a hysterectomy if they get an infection. So that's why they get preoperative antibiotics, they get go-home antibiotics, and when we check on them all the time, it's always, okay, are you having any discharge that isn't right, because that could be a sign that something's infected. But it's really rare.
Okay, good to know. Let's talk to Pamela on the line. Pamela, thank you for calling in tonight to Medical Monday. What's your question?
Well, I would like to know if this procedure is recommended for young women in their 30s that would like to have a child later.
Okay, great question. Thank you, Pamela.
Very good question. We tell women on the front end that, there is no guarantee that you will be able to become pregnant after this procedure. But
and why is that?
Well, because, the endometrium grows off of the myometrium. That's all fed by the same set of blood supply. So, that could inhibit reproduction potentially. And if you got any of those little particles in the ovaries, you could create premature menopause. Again, very unlikely. But there have been hundreds and hundreds of cases of women that have gotten pregnant after fibroid embolization. So, most of the time we try to, steer it to that population of people that are done having their children and having problems and waiting for menopause. But that doesn't mean that you can't do it to someone younger. I mean,
because what options does a woman have who still wants to have children but is dealing with very painful uterine fibroids?
Well, hormonal therapy, that would be the only one, but that would affect pregnancy
your
too.
Fertility. Yeah.
So it's kind of, I mean, probably if a woman that was 30 had, an 8-centimeter fibroid on the top of her uterus and it was causing problems, the OBGYN would probably recommend that they go in and take off that one fibroid, a myomectomy. And that would be an option that you would weigh against fibroid embolization. And there's still risk. I mean, you have a myomectomy, there's a chance that you can have an injury to your uterus and you can't carry a child too. So everything we do has risk associated with it. And no one can give you hard and fast numbers really for any of those really that, you can have a 2% risk here or a 4% risk here. Everyone's kind of halfway guessing anyway.
A risk,
so, yeah, so I mean, it's doable. And, I mean, the women, and the reason, part of the reason it's been proven, in fact, I had to do it probably a month ago, postpartum, 22-year-old lady, bleeding, can't surgically stop it, embolize her uterus. I had to explain to her that, I can't guarantee, but, you may not be able to have children after this. But it was either that or a uterus was coming out. So she said, do it, please. I mean, I want to at least preserve everything I can. Right. So it's a little bit more extreme than what she's asking, but it's the same idea.
So it's one of those things that if you still want to have children, you just really need to have some good conversations with your doctors and say, okay, let's weigh some options here. Yeah. And that's a tough one because you are taking a little bit of a guess and a little bit of risk every time. Okay, we're going to take another quick break. If you have a question about uterine fibroids, go ahead and give us a call tonight. 737+ is the number to call. We're coming right back.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
I'm News Channel 5 meteorologist Henry Rothenberg with your Storm 5 weather forecast. Most of us remaining dry continuing through your Monday evening. It won't be until after midnight we see rain chances returning to radar. Temperature-wise, we are actually pleasant, a little bit below average out there. Humidity not too bad as well. You can see more specifically the conditions at Nashville International Airport showing you just that. These are updated every hour. The forecast as we head into tonight, down to 60 degrees. but after midnight, those scattered showers expected. Not really expecting much in the way of thunderstorm activity, although that will be later in the week, which you'll see in the 7-day trend. Speaking of the 7-day, on Tuesday, we top out at 83, so still below average. Our sky clearing late in the day. Back to normal on Wednesday with a partly cloudy sky. Hot and humid with storm chances minor, but there on Thursday. That continues into the end of June on Friday and start of July on Saturday.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. Big time.
This summer, one of the world's most popular mobile games comes to CBS.
This is Candy Crush. Yeah, baby.
Tasty.
10 seconds to go.
This is crazy.
No time for fear.
Mario Lopez hosts Candy Crush. Series premiere CBS July 9th.
Welcome back to Medical Monday. I'm here with Dr. Dan Wunder. He's an interventional radiologist, and I ask you every time you're here, explain exactly what that is, because we're not used to hearing that.
I think the best way to explain it is a minimally invasive surgeon, really.
Okay.
I mean, radiologists are trained in imaging, ultrasound. I mean, that's our basis. That's how we make diagnosis on people. You know, X-ray, ultrasound, CT, MRI, etc. And what interventional radiology is, a blend of that as far in a minimally invasive procedures, where we can do tremendous things inside the body through tiny little pokes, you know, in your skin, anywhere in your liver, your arteries, to help fix things inside you. All kinds of tools have been developed to put stents in, ablate liver tumors, kill off liver tumors, all things like that. You know, I mean, it's just a really wonderful field that began in the 70s, mid-70s, basically.
And your dad, right? Am I remembering the story correctly? Was an interventional radiologist?
He was a radiologist.
He's a radiologist.
Yeah,
okay.
He was. That was before actually they had interventional radiologists. So he learned. You know, he was read the films and the CTs and the ultrasound. So. And
you have at least one son following in your footsteps?
Yeah, one's in medical school right now,
Oh, that's pretty cool. Very cool indeed. Okay, back to the topic at hand today, uterine fibroids. Women who suffer from these are often in a lot of pain. They're dealing with heavy periods. And when we say heavy, we're talking heavy periods, to the point where it affects your lifestyle. And you do a procedure called uterine embolization. Can you kind of just give us the overview again if people are just joining us here at about 7:30? What is that?
Sure. Embolization is a process, it's a fancy word, it blocks blood flow, it blocks flow of something. And when we put these tiny little straw-like catheters in the arteries and steer them around, we can put them in different places, and we put material through those catheters, sterile material, to block the blood flow wherever it is, whether it's in the liver or the uterus or the prostate or a bleeding vessel in a trauma case or something like that. We can stop that without you going to surgery, basically. So fibroid embolization, you have these benign, non-cancerous tumors of the uterus, and they're causing problems, mostly bleeding, but other symptoms also. And you are, you know, in a very non-invasive fashion, minimally invasive, I should say, you know, starving them of blood flow, making them shrink so that they quit bleeding or markedly reduce their bleeding. So.
And this is highly targeted. You're not going to affect the entire uterus per se, right?
Well, yes and no. Yes, the uterine artery is what you embolize.
Okay.
But whatever's in the uterus, a fibroid, is dilated the blood flow to it, so it's sucking most of the blood flow to it. So when you're done, the blood flow isn't going through those arteries much anymore, but there are a lot of other tiny arteries going to the uterus, so the uterus doesn't die. You're basically, you know, embolizing the area that's the most vigorously growing, I guess you'd say.
Now, even though you're starving these uterine fibroids of their blood supply and blood flow, they don't then just kind of fall off and die of what we would think of, like, you know, if you put a tourniquet on your arm, eventually it's going to fall off if you just did that. But that's not what happens.
Well, in very rare circumstances, it can. In very rare circumstances, you could actually pass a fibroid like during your period.
Okay.
I mean, they're small and they can come if they're located on the inside of your uterus. There's the fibroids are either in the middle of the muscle of your uterus, they're on the inside next to the lining of your uterus, or they're on the outside of the uterus.
Okay.
So it is possible to pass a fibroid or for it to fall off. It's very rare. They used to worry about that a whole bunch. What they call pedunculated fibroids, kind of like on a stalk.
Sure.
They worried that if you embolize those, the stalk would necrose and poof, falls off somewhere. They don't really see that very much, quite honestly. But some of the inside ones can come through. It's not real common, and I don't know that how often it's not. I think it's been reported to me once by one of my patients that they noticed a little more tissue at one point than normal. But most of the time, what you're doing, the vast majority of the time, is that fibroid, you're shrinking it down about 30%, which is a big change in volume. And if you have several of those, you know, a uterus that feels this bulky gets like this, it's like a world of difference to a lady. So.
Okay, let's hop to Rowena. Rowena, thank you for your patience. What's your question tonight?
My question is, what size fibroids would be too large for the
embolization? It is a mouthful. I tell you what, Rowena, great question though. What size is good or bad?
As I think I said before, about 20 centimeters. I mean, was kind of the rule of thumb. We try to stay that size or below, just because the bigger they get, the bigger a risk they have of becoming infected in the middle, and that's still not big. And I've done plenty of them that are that size, but you know that's kind of at least where I kind of try to draw the line, because it's so big, it's hard to get all that blood flow stopped in a fashion that's pretty safe. So.
Okay. So with 7 centimeters, would that be good?
Yes, ma'am.
7 centimeters.
Yep, that's good.
And Rowena, if this is something that you're dealing with, we're going to put up numbers here at the end of the broadcast here, so go ahead and get your pen and paper ready. We'll tell you how to get a hold of Dr. Wunder so you can discuss your options a little bit better and understand what this all is about. As folks deal with this and maybe do the embolization, what can they expect in the week after to the 6 months after this?
The initial, the first couple days, and I've said, it can be kind of difficult, like a real bad crampy period.
Yeah.
Most women, it kind of varies, like from not noticing too much of anything other than a pretty difficult period to there's some women that have a good amount of pain. Caucasian women usually have a little bit more pain than African American women. I'm not sure why, maybe, but I noticed that over the years. But after that first couple days to 3 or 4 days, then they pretty much go about their normal activities. I haven't been any feedback we've gotten. Man, the clinic hasn't said that they've changed things much. The biggest question is, what about the bleeding? The bleeding tapers off. It just doesn't stop automatically. It tapers down. Okay. So that's kind of one of those things that improve over time, and it can take up to 4 weeks to 6 weeks to taper down to something that's more.
This is bleeding after the procedure, or bleeding with your period that may be especially heavy?
Bleeding with your period. You're not going to bleed after the procedure.
Okay.
You're not. Sorry. It's your normal menstrual cycle is going to get lighter and lighter, basically. Trying to get back to a normal menstrual cycle, not a really heavy cycle.
So that would take how long again?
It could take 1 to 2 cycles potentially.
Okay.
When they start to really see, at least what we've seen in the clinic, it's more improvement at 4, 6, 7 months, where the fibroids are starting to shrink down, and then there's some of those other secondary symptoms like urinary frequency, because that uterus is being squished on the bladder, and some of those other things like that. The pain in the pelvis, that's going to start to get better and better, but it takes a little while for that to happen. It's not tomorrow.
Right. And you're going to see there on the MRI or the ultrasound, you're going to take the measurements before surgery and then after, and continuing on and say, actually, they've shrunk this much. So it's often good to actually see the evidence, of what's happening inside your body. We have Terry on the line. Terry, good evening to you. What's your question?
Hi. I was actually wanting to know, is there a lot of downtime on that, and is it actually surgery? Are you going in for like an office visit, or is it something you have to prepare to be out of work for a while?
All great questions.
Most women have this procedure done like on a Wednesday or Thursday. They come into the office. Yes, it is an office visit. We usually have that sometime a week or two beforehand because of the pre-certification process with insurance company. We have to document all this so that we can get it approved for you. And then so when you come in and have it done, they usually pick the middle to end of the week and have some days off so that by Monday, after 3 or 4 days of rest, they're ready to go. Now some women want a little bit more time, and most of those women know that they need more time to recover from things, and then they plan it as such, maybe like an extra week off or something. But it is not a surgery; it is a procedure. So you will be sedated. You will need a driver.
Are you knocked out sedated, or are you kind of like loopy sedated?
No, you're snoring sedated.
Okay, gotcha.
Yeah.
Okay.
So you don't remember it. I mean, those drugs are given so you don't remember it. You'll need a driver, and there's going to be one little incision that's about 1/8 of an inch next to your groin on the right side. Usually, that's where all the work was done from, and you have a little bandage on that you go home with, and you take off the next day. So, I think is that all your question was, ma'am?
One more.
Okay.
Will this one procedure take care of all of the? I mean, is it a one procedure for all of the uterine fibroids that you guys noticed inside, or is it going to be more? Will I have to go back? I think I have about 8.
Okay.
So I guess my question is, will all 8 of them be removed if I decide for this?
All 8 of them should receive the therapy that's put through the catheters. Okay, we can't select out 1 or 2 or 4. I mean, it's going to get therapy from both sides, your whole uterus. Now there's about a 5% rate of having to redo this within a year if your symptoms still haven't got to where you want to be, and we need to go after them again. But so they'll all be treated.
Terry, thank you for calling in with some great questions tonight. Really appreciate hearing from you. And that was a question I had during one of the breaks. Do people have one fibroid, or do they usually have more than one? You said definitely more than one.
Yeah, usually it's pretty rare just to have one, but it's possible. But most of the time they have multiple fibroids.
And again, you said there's no rhyme or reason why this happens to women, right?
No, it just happened. I mean, we don't. There's some mild correlation with increased weight. There is some mild correlation with lack of exercise. So they say that, and African American women usually have more fibroids than Caucasian women. So, those things you could do to help yourself. And there is kind of a familial predominance to it too. So it does run in families some. Oral contraceptive use does not cause fibroids to occur. Okay? There's kind of a misconception that's out there at some point. So.
Okay, all good to know. And great questions. I think that people, you can definitely tell that women want to know, what are my other options? Maybe I don't want to have a hysterectomy for whatever reason that may be. You still want to have children, or you just don't want to have a big surgery like that, because it is a very serious surgery.
Yeah, it's a big surgery.
Yeah. All right, we're going to take another quick break. When we come back, more of your questions and calls. That number to call, 615-737+. We will get those calls lined up during the break. Stay with us.
I'll be right back. Hi! You think you're probably sober?
Yeah.
But you're thinking about taking the back roads home, just in case. If you're probably sober, then why would you do that? Good choice.
Probably okay isn't okay. If you see a warning sign, stop and call a cab, a car, or a friend.
That's a full glass of wine. I'll be chatting you later.
Sometimes feel you're only halfway ready for the morning? Running at half speed? With half the time and half the energy.
Good
News Channel 5 this morning makes you feel home.
Breaking news.
Armed with information. The breaking news you missed. Your day planner forecast.
Great way to start the day.
And the only bird's eye view of traffic with Sky 5.
Following several stories.
Get the news you need to take on the whole day. Watch tomorrow starting at 4 a.m.
What's with truckers who speed when it's raining?
The lack of signaling by drivers is quite frustrating.
Do these rants sound familiar?
Come on, man, just use your gas pedal.
If you drive around Nashville, chances are you have a road rant of your own.
Please don't stop.
It drives me insane.
I'm not a mind reader.
Left lanes are for passing.
We want to hear them. Send them to newschannel5.com/road rant.
Are you nuts?
But please don't record your rant and drive.
When you're on the move, make sure you stay in the know.
Continuing to follow breaking news.
Because the breaking news that matters to you
Traffic is backed up for miles.
can come from anywhere.
Protesters have been
at any time.
Showers expected.
See it
Skyfire
as it happens.
rolled over school buses.
Wherever you are.
Storm cell that's coming
News Channel 5 streaming live.
Quite a bit of lightning here.
Stay safe.
Take a look at this, Skyfire.
Stay connected to your news and information leader. Live streaming of News Channel 5 is sponsored by Universal Kia.
The music, the foot-tapping, head-bobbing, soul-saving kind. Country, blues, rock, and everything in between. Where it all started and never stopped. Heard on stages, porches, and street corners. You can't download it. You can only experience it. The soundtrack of America, made in Tennessee. Start planning at tnvacation.com.
You work hard for your money.
Make the most of every penny.
I'm John Maxon.
And I'm Pete Benson. We're hosts of Beacon Retirement Strategies right here on News Channel 5 Plus.
It is the most important thing. Each week we'll offer expert advice and proven strategies
to help you keep your money and enjoy your retirement.
Beacon Capital Management presents Beacon Retirement Strategies. Watch Thursdays, Saturdays, Sundays, and Mondays on News Channel 5 Plus.
Welcome back to Medical Monday. We are talking about uterine fibroids today. If you have a question about uterine fibroids and different options you have, go ahead and give us a call. Dr. Dan Wunder's here, an interventional radiologist, to talk about that. And the area code is 615-737-PLUS is the number to call. And, you know, Dr. Wunder, I've done a couple of shows with you now. I know you're a straight shooter. You like to just tell it like it is and lay the options out on the table. And you say that's very important for women who are dealing with uterine fibroids to especially know there are options.
I think that's, you know, just to be blatantly honest, like you said, you need to ask questions. I mean, it's your health, you know, and no matter how much you trust your doctor, there's any one of those doctors is seeing lots of people and they have things to manage. And for you to stay on top of it, ask questions, be inquisitive. I'm not saying not trust anyone, but, you know, there's always more than one way to skin a cat.
Yeah.
So you should be asking about those things, you know, and if someone doesn't think that's a good idea, why is that not a good idea? I told you during the break, I mean, there's people I recommend for a hysterectomy when they come to see me for a fibroid embolization because I don't think it's the best thing for them. So, I mean, that should work uniformly, of course, across the gamut of healthcare. It always doesn't, but it should. Right. But the patient's in charge of their healthcare, and they're the ones that need to demand the best and ask questions to find out things. And the internet, of course, is a great tool. I mean,
sure, it's a great
Google anything.
Yeah, if you put, you know, uterine fibroid options, you're going to come up with a whole list, and embolization is going to be on that list if you search it out. Who makes a good candidate for this?
One of the better candidates, I think, is that the woman that's perimenopausal, you know, that's having considerable symptoms, mostly bleeding, but some of the other ones I've talked about, that's looking for that bridge, you know, into menopause, that doesn't want to have a hysterectomy. And most of those women know that. And it's the downtime they don't want to have from a hysterectomy, or at least what they perceive is, I mean, downtime. And so that's probably one of the better candidates, I think I would say, because they have certain expectations, you know. And that's with anything, any process that any procedure any of us do, you have to realize that, you know, nothing that we do is perfect. And you know, I'm not going to make your fibroids go away by doing this procedure. I'm going to shrink them. They're going to make you feel better. You know, you're going to feel better because we've done this, and it may require retherapy, you know, or it may not until you get to where you want to be. But if it makes you feel good enough and your life is less problematic, we've achieved what you need. And those kind of women, they understand that, and they come with the right expectations. So it makes it easier to take care of people like that because they know what they're getting into.
Yeah, I got some stats before the show, and it said 80 out of 100 women treated with the embolization report that their symptoms have improved, but that 1 out of 5 will maybe have to repeat it. You think that's pretty fair?
It's probably a little lower than 20%. It's probably more like 10, but you know, I mean, it does have to happen sometimes if they have a lot of fibroids or a bigger fibroid, and when you do the embolization, if you do it what I call a hard embolization, which is like really pack all that stuff in there, they're going to be a lot more symptomatic than if you do a moderate amount, you know, so that their symptoms are better, but they're not just like in, you know, horrible discomfort post-procedure. So you got to weigh that. There is no line in the sand for that. It's all experience. Yeah, it doesn't exist, unfortunately. So you're trying to, you know, weigh the personality of the patient, the disease process they have, what you think they can tolerate, what the arteriogram looks like, when the stop point is. So it's a fluid end. You just have to try to figure it out as you go.
And that's why you also want to find somebody who has experience doing this.
That's true.
It's very important. Okay, let's hop to Elizabeth on the line. Good evening, Elizabeth.
Good evening.
Go ahead with your question.
Yeah, so I actually got diagnosed with fibroids today, and I'm kind of curious about the hysterectomy because I just popped onto your show here. But I was kind of curious if I were to go into the hysterectomy, it's just due to the fact that I am actually going to be turning 30 this year, and of course, you know, I know the fact that with, you know, if I was wanting to have children, you know, in my 30s, you know, there might be complications. But what is, like if I were to go the route with the hysterectomy, how long is the procedure and what's the recovery time with that?
Elizabeth, I just want to double check with you. Dr. Wunder does the embolization. Is that what you're wondering about, since you still want the possibility of having children? So the embolization, wondering about the downtime, right?
Yes, exactly.
Okay.
It's usually a week or less in most women. I mean, usually a little bit on the 3 or 4 day side. Some could be up to a week or a little bit longer, but you know, it's not like downtime, like you can't drive a car or you can't go to work. You know, the first couple of days are that real bad menstrual cycle kind of pain. Usually 1, maybe 2. Again, some are a little bit outliers on that. But you know, I mean, women are pretty tough, and a lot of them function with that every day. Right. So it's hard for me as a man to tell you that you're going to have downtime because you have, you know, this pain that's a quarter of what your menstrual cycle pain is, and you can do whatever. So there's no restriction. The only restriction is no driving for 24 hours because narcotics you receive, and no heavy lifting for 2 days. Those are the real restrictions. That's your downtime. And the heavy lifting is like, you know, more than like 25 pounds. So there's some women that are, you know, going the next day like nothing ever happened. So. But you know, you're 30. You already. I mean, you know, I'd be happy to talk to you about it. But again, if you're just tuning in, the thing about embolization is that, you know, we have to have that discussion about desire for childbirth, any more childbirth. If you're sure you're done with it, there's no question. If you're questionable about whether you still need more children or want more children, then fibroid embolization is still an option, but there's no guarantee that, you know, you'll be able to get pregnant. I just have to make sure you say that.
I understand. Okay, that's what I was wondering. Thank you so much.
Elizabeth, thank you. Let's talk to Stephanie. Stephanie, good evening to you. What's your question?
Hi. I was wondering if the doctor could recommend a diet or food, physical therapy, or supplements to buy time, the age of 50 to 55.
To try to bridge that gap if you don't want to do the embolization or do the hysterectomy, that sort of thing?
Exactly. I've gone from 1 fibroid to 3, and I've had reactions in the past to Toradol and contrast dye, but my symptoms are getting to a point where they're rather unbearable. But I don't want to have any type of procedure. I was trying to wait until maybe to go through the process of menopause, and maybe that would correct the problem.
I don't know of natural remedies. I know there's one lady that saw me that her mother just swore by, I think, evening primrose, I think it was. She just, that was what she recommended. Or I did an embolization on her daughter, but I believe it was, but her mother was treated well by herself with that home remedy or allopathic remedy. Exercise is supposed to be helpful in stemming the cause. Weight loss is supposed to be helpful in stemming the proliferation of fibroids. I don't know if that's really documented or more of a, kind of a side kind of thing. You may want to talk to your OBGYN about hormonal therapy. and it's because oral contraceptive use and gonadotropin releasing hormones inhibitors will help make those smaller. When you stop taking the medicines, they'll come back, but that may be something you're willing to do to bridge the time. But that would be an OBGYN taking care of that.
Stephanie, I hope that helps you out. Good luck.
It does. Thank you.
Thank you for calling in. We've had great questions tonight. And I'm sure it's stuff that you hear in your practice all the time when women come in, just really researching what to do, how to do it, when to do it.
Yeah. They do. They spend a lot of time. When they show up, they know, what they want done and what's going to happen for the most part. They have a few questions, but, they're very knowledgeable about this. This is one of the few things that, they tell me, it's like, when are we going to do this? I know I want to have this done. I make a point of going through all this stuff, but they've
already made up their mind. I got it down, Doc. Well, let's go.
Yeah,
let's make the appointment.
Next week on Friday.
And this isn't a newfangled thing that's been around, but it also hasn't been around for, 7 decades or something.
No. Yeah, it's just, as I spoke earlier, we talked about embolizing the uterus postpartum, and that's where it came from. I mean, we embolize all kinds of stuff every day. People that have GI bleeds from, ulcers and stuff like that, postpartum hemorrhage, all things like tumors. So this is just a kind of just steering the catheter another direction and putting it in a different organ, and just a reapplication of an existing technique would be the best way to say it.
Yeah, it's really neat how it came about. All right, we're going to take another quick break. When we come back, we're going to give you the name and number, the email address, where you can call to get information to go see Dr. Wunder to talk more about embolization and go from there. So get your pen and paper ready. We're coming right back.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
I'm News Channel 5 meteorologist Henry Rothenberg with your Storm 5 weather forecast. Most of us remaining dry continuing through your Monday evening. It won't be until after midnight we see rain chances returning to radar. Temperature-wise, we are actually pleasant, a little bit below average out there. Humidity not too bad as well. You can see more specifically the conditions at Nashville International Airport showing you just that. These are updated every hour. The forecast as we head into tonight, down to 60 degrees. But after midnight, those scattered showers expected. Not really expecting much in the way of thunderstorm activity, although that will be later in the week, which you'll see in the 7-day trend. Speaking of the 7-day, on Tuesday, we top out at 83, so still below average. Our sky clearing late in the day. Back to normal on Wednesday with a partly cloudy sky. Hot and humid with storm chances minor, but there on Thursday. That continues into the end of June on Friday and start of July on Saturday.
For more than 15 years, Tim Takas has been answering your questions on Morning Line and Open Line. Now Tim and law partner Barbara Boone McGinnis have their own hour devoted entirely to elder care law. These are issues every family will face. Start finding answers. Watch the Takas McGinnis Elder Care Law Hour. Friday mornings at 9 on News Channel 5+.
If you've got a yard, you may plan on digging in it, like to build an addition, put in a pool, or bury your pirate booty. But you should know that throughout the country, there may be pipelines buried underground, and if you hit one, you've got trouble. So before you dig, call 811 to have any buried pipelines located and marked at no charge.
Call your local natural gas utility or visit pipesafety.org. Brought to you by the Tennessee Gas Association.
Welcome back to Medical Monday. As promised, I want to get you this information, how you can talk to Dr. Wunder and get a hold of him. You can email him at medicalmondays@ouradvancedhealth.com. That's a lot to get right there, so just give him a call. That might be easier. Here's the referral line, 615-986-6033. Let me say it again, 615-986-6033. Call that line. They will get you to Dr. Wunder. Just name the topic that we were talking about today, uterine fibroids, Dr. Wunder's name, and they will get you to them, and you can make an appointment. What should people expect when they come in for that first appointment? Do they need to bring information maybe from their OBGYN, their reports, that sort of thing?
The best thing to bring, if they haven't been imaged at Premier Radiology, our network of imaging, or St. Thomas, because we can see all of that imaging.
Okay.
That's all something we can put our fingers on. If they have an image like an MRI or an ultrasound from another facility, bring a copy on a disc.
Okay.
Don't really need the report. It's nice if you have it, but we need the disc. List of their medications, and any other medical history that they have, that either if it's not innate to them, written down. It's always wonderful when patients show up with a list of all their medications, their allergies, and all the surgeries and their dates. It's great.
Here.
Yep, exactly. I highly advocate everyone to do that. That's a wonderful thing, because it's just a snapshot. It really helps them out a lot. So, but that's what they need to when they show up for that first visit.
And most of the women you see know they have fibroids. It's not like a diagnostic thing where you're like, yep, you've got them.
Yeah.
They know they have them, and then you can talk about the options, right? You're going to kind of lay it out once you get a look at what you're dealing with.
Yes, ma'am.
And talk about the pros and cons. We talked about who makes a good candidate, and I know it's kind of the reverse, but who makes a bad candidate for this, for the embolization?
Really large fibroids, those, there's more risk with those. It's not like you can't do it, but if you have because not all, to digress here a bit, not all patients come to us from an OBGYN. A lot come just by themselves. And the OBGYN's in their life in the background, but maybe not so much advocating a different form of treatment. So if we have a large fibroid, or a set of large fibroids in a woman, we really want to have an OBGYN that's on board, because if you have a complication or an infection, they're going to have to help manage that to some degree. So that's important. So that's probably, that's a person that's not a great candidate. Maybe someone that's really young, that really, is still actively childbearing. I wouldn't be advocating it real strongly.
Well, Dr. Wunder, thank you for walking us through all this, providing some great information today, and I always love learning from you. Appreciate it.
All right.
Thank you for watching tonight. Go ahead and give Dr. Wunder a call if you want to set up an appointment with him. He's out in Madison. Have a good evening, everybody.